This is an EKG of a 50-year-old after a cardiac arrest with return of spontaneous circulation, or ROSC. Let's learn to read this like a cardiologist. What do you see? Okay, let's take a systematic approach in reading this EKG, starting with the rate. There are 15 beats in this 10-second EKG, meaning that the rate is about 90 beats per minute. Next, let's move on to the rhythm. The rhythm appears irregularly irregular with no discernible P waves. This suggests that he's in atrial fibrillation. Next, let's look at the axis. The axis is normal at about 90 degrees, given the QRS complex is isoelectric up in lead 1 and positive in leads 2, 3, and AVS. Fourth, let's talk about the intervals. The intervals all appear normal, and the QRS complex is narrow with appropriate R-wave progression in the precordial leads. This means that the QRS complex goes from negative to positive around leads V3 and V4. Finally, let's talk about other abnormalities on this EKG. Notice up in AVR, there are ST segment elevations of about 2 millimeters, as well as diffuse ST segment depressions and T-wave inversions in the anterolateral leads. Okay, so let's put this all together. What do these findings suggest? Along with his history of a cardiac arrest, the ST segment elevations in AVR, as well as the diffuse ST segment depressions, suggest global cardiac ischemia with an obstruction of the left main or proximal left anterior descending coronary arteries. So you recognize these EKG findings and you turn the patient appropriately for a coronary angiogram. Surprisingly, the angiogram does not show any obstruction in his coronary arteries, which is not what we expected to see. But the patient remains obtunded. What would you do next? Head imaging, great idea. The patient is taken for an urgent non-contrast head CT, as shown up here. What do you see? Our patient has a subarachnoid hemorrhage, as seen by the bright white on the cisterns. Remember, on a non-contrast CT, blood will appear as bright white, whereas CSF is going to appear as black. There's also severe cerebral edema, as we can see by distortion of the gyri and the sulci, as well as a loss of gray-white matter differentiation, which means that there's an increase in intracranial pressure. But what does this mean for his EKG? His EKG findings are likely due to a subarachnoid hemorrhage and increase in intracranial pressure, which is a finding that is also known as cerebral T waves. How do you notice cerebral T waves? A common EKG finding is deep T-wave inversions of at least 5 millimeters in 4 contiguous precordial leads, as we see here in leads V3, V4, V5, and V6. Other common EKG findings in subarachnoid hemorrhage include ST segment depressions, arrhythmia, such as our patient with atrial fibrillation, QTC prolongation, and bradycardia is part of the Cushing reflex. Remember, the Cushing reflex occurs in response to increased intracranial pressure and is characterized by the triad of respiratory depression, bradycardia, and hypertension. It's often a warning sign of impending brain herniation. Now, why the cerebral T waves occur is not completely understood, but is thought to possibly be related to a catecholamine surge from the brain that leads to myocardial supply and demand mismatch and possible global cardiac edema. All right, we covered a lot today. Let's review our main takeaways. First, in our patient after cardiac arrest, who had ST segment elevations in AVR and diffuse ST segment depressions, you should be concerned about global cardiac ischemia from occlusion in the left main or left proximal anterior descending artery. Second, a coronary angiogram is warranted. However, in patients who do not meet criteria for a STEMI and who are obtunded, consider non-contrast head CT first. In our patient who presented obtunded, his coronary angiogram did not identify any occlusions. However, his non-contrast head CT showed a subarachnoid hemorrhage. And lastly, this brings us to cerebral T waves, which can be seen in patients with catastrophic neurologic injuries and increased intracranial pressure. Other EKG findings in these patients include QTC prolongation, arrhythmias, ST segment depression, and bradycardia.